Hi, and welcome to HMS 290, the sports medicine team. By now, you should have gotten done with the PowerPoint, and I wanted to take just a couple minutes to go ahead and expand on some of the points, or I guess at least verbally describe some of the relationships of the sports medicine team. And so let's just run through again. We've mentioned the athletic trainer, the team physician, the strength conditioning specialist, the sports psychologist, the nutritionist, physical therapist, chiropractor, other physician specialists, the massage therapist, the EMT, the dentist, the exercise physiologist, and the biomechanist. Is this an exclusive list? Absolutely not. These are probably just the ones that we deal with on a most common basis. There are certainly other people that we would utilize, but probably less common than the ones that have been mentioned here. So, and they kind of almost go a little bit in order of the type of people, at least in my experience, that I've interacted with on a day-to-day basis. So the athletic trainer is typically the primary caregiver, or the gateway person, as I guess I kind of like to see it. Again, they're there when the injury happens. They're there to make the assessment, to do the referral, and then typically to do most of the rehabilitation, if not all, and then help with the return to play decisions that the team physician is ultimately responsible with. So that said, the team physician's role can vary by setting. Again, in a high school setting, the team physician may not have as much of an umbrella role over return to play decisions. A lot of times the family physician will be the one, or the person's, again, orthopedic surgeon will be the one to make those types of return to play decisions. But in the college setting, such as where most of my experience is, and even in the professional setting, even if a family physician or some other physician clears this person to play, for example, let's say a sprained ankle that took about a month and a half to rehabilitate, and their own personal physician clears them, it is the ultimate role and responsibility of the team physician to literally grant that person the okay to play. So again, settings can vary as far as how much involved the team physician is. Certainly in a professional setting, like let's say professional football, that person, the team physician, is probably there on a day-to-day basis. Certainly the athletic trainer is there for every practice and every game, but the team physician, again, in a high school setting, is probably only there on football Friday nights, and then a kind of on-call and see you in the clinic kind of basis. So I just kind of wanted to clarify that a little bit. One of the other things I kind of wanted to hit on was the team physician may be a general medicine physician, or maybe an orthopedic surgeon or orthopedist. Those are the typical two specialties, I guess you could say. The general medicine physician will, be able to treat colds, illnesses, asthma, general medical issues, as the name kind of indicates. Orthopedic physicians, a lot of orthopedic injuries happen, so that makes sense for that type of physician to be a team physician. And sometimes you will have more than one team physician, but you may have one overall director. So for example, at a major university, there may be 3, 4, maybe even 5 physicians involved with the athletic program. However, there will be one person who is the overseeing person for everybody and makes the tough calls, makes the policy and procedure calls, makes the overall return to play decisions. As far as orthopedics go, again, you may even have a few different involved with yourself, or at least affiliated with your program, such as you may have somebody who's a knee specialist, you may have somebody who's a shoulder specialist or a hand specialist, and maybe even a spine specialist. All those make sense. Those are very common injuries, or very common sites for injuries in athletics, and certainly also the foot and ankle. So you may have affiliations with every one of those kinds of specialists, as well as, now getting away from orthopedics, let's say even a cardiologist or a dermatologist or a neurologist for somebody who has maybe a neurological issue, or let's say a concussion that is significant or severe and needs some follow-up and further evaluation. So those are all very common people to have, I want to say, in your back pocket, but certainly in your Rolodex, so that you can access them quickly and you build up relationships with those people to really help the student athlete or the athlete, whatever the case may be, in their best interest. And again, are those exclusive? No, those are the most common, though, that we probably see. Now, I did want to go ahead and expand a little bit on the last slide, the one that was probably right before you clicked on this link, and that is the example of integrated care. So let's say we have somebody who, let's use football again as an example. It's easy, it's that time of year. So let's say we have a player that goes down with a knee injury on the field. The athletic trainer does a little trot out there and goes ahead and evaluates the knee injury and suspects an ACL tear. In this case, I would go ahead and say, all right, we need to refer this to an orthopedic surgeon, and again, one who specializes in knees, preferably somebody who's a sports medicine knee specialist as well. So this person then gets an MRI, and then they get the reconstructive surgery because, yes, that's indeed what it was. It was an ACL tear. And then they can look forward to about 6 to 9 months of rehabilitation. In this case, the person would be referred back to the athletic trainer or a physical therapist, or even both may work hand in hand in providing the treatment or the rehabilitation post-surgery for this ACL rehabilitation. Let's say during this process, we notice, hey, this person's got some weird jumping mechanics. Not only that, but we are able to discern that this person has some anxiety about returning to, let's say, football. Let's say it was a big collision that the injury happened on. They were making a tackle, and they're nervous about having this major injury happen again and losing another 6 to 9 months, or what would they do? And they just have anxiety. And then let's say they're getting closer to, they're being very functional, and they're getting closer to return to play, and they don't necessarily need daily treatment. Well, for all three of those reasons, I would refer these people potentially to other specialists. So I might refer this person to a biomechanist to evaluate some jumping mechanics, or if they have some force plate studies done on this person. Another person I might refer this person to, because of their anxieties and their fears, is a sports psychologist to help with the return to play anxieties that this person is experiencing. And finally, I may actually say that this person gets referred to the strength coach to develop develop another relationship with another professional in taking over the rehabilitation, if you will, the building of the muscle mass, doing some other drills for the knee. Not only that, but just because their knee is hurt doesn't mean that the rest of their body is hurt. So there's conditioning and lifting programs that can still be done and make that person still feel involved as part of an athlete and part of a team, because that is, after all, part of their identity. So it's not just as simple as just showing up for rehab and then completing exercises and then see you next time. It can be a lot more involved and integrated in that. Let's say this person is moving along just fine with all these other specialists and has cleared those hurdles, if you will. This person then ultimately does need to be cleared by the team physician. And in that case, again, when they're psychologically ready, emotionally ready, they have great strength, they have no pain, and they're very good functionally, this person then would be hopefully cleared by the team physician. Does that mean that their rehabilitation ends? No, a lot of times past clearance. Clearing usually means that this person is 90% or better, and they're usually clear at that point. When we do that, we have to continue rehabilitation. And not only that, but we want to protect that joint because, again, we're missing about sometimes 10%, maybe not quite, but maybe about that much. And so in this case, we will go ahead and possibly, put this person in a brace before they return to play. Again, that can depend, and you'll see later on in the course that there's some theories to braces and not braces, and should I brace, should I not brace? And again, certain physicians will have their feelings, certain professionals will have their feelings about whether or not to do that. So anyway, in a nutshell, that is a case of where several professionals and members of a sports medicine team may be involved.